Hello, everybody. Today is the 9th of April, 2021. This is our 13th webinar of season 2 and the end of season 2. And it's our 36th webinar of all webinars from our Ain Shams orthopedic platform. I do believe that in spite of the era of pandemic and social distancing, we continued our mission of online education for our students and colleagues all over Egypt and the Middle East, seeking perfection and proving that Egyptian can approach perfection whenever there is intention. Seen in the Pharaoh's golden bed a few days ago, and proving that Ain Shams orthopedic department will continue to be the hub of orthopedic surgery in Egypt and the Middle East. Today, we will continue the subject of fracture-related infection. You remember the last week, we are dealing with updates and management. Today, in part 2, we will deal with induced membrane techniques. Our moderator today will be our distinguished panelist the last week. He's our moderator today, Professor Dr. Mahmoud Mahran. We have a very strong panel, starting by Professor Salah Abu Saif, the head of the Reconstruction group, and the pioneer of external fixators and reconstruction, and Professor Dr. Mu'taz Fuad Taqib. He's an expert and a very distinguished surgeon in this area. And we have two guests from Germany, again, Professor Andrew Trampuz from infectious disease consultant, Charité University Hospital, Berlin. And we are happy to have him again with us this week, to exchange our knowledge with him and to make the subject, the tough subject we are dealing with very easy, and to share his wisdom in all the decisions we asked him for. And from Spain, for the first time, we have Professor Cristina Ojeda. Thanks, Cristina, for joining us. She is from 12th October University Hospital in Madrid. And we have a bunch of our distinguished speakers, Dr. Ahmed Mansour, and Dr. Mustafa Baraka, and Dr. Muhammad Od, and Dr. Michael Amir. All of them will have a very distinguished cases. I hope you a fruitful night, and I hope that you have spent with us a very fruitful season 2. And after today, we'll have rest for the period of Ramadan and our Eid al-Fitr, about 8 weeks of rest, and then we'll start our third season after this. I hope you a fruitful night, and I will turn my mic to Professor Mahran to start moderating this webinar. Fadal, Dr. Mahran, please.
Thank you, Dr. Amr, for the introduction. This is our second webinar in fracture-related infection. We are going to speak about the special issue of post-infectious bone defect reconstruction, and this time by the induced membrane technique. As we all know that in the past 20 years, there has been steady increase in publications about bone reconstruction by the muscular technique. We all know that our department is experienced in limb reconstruction by distraction, osteogenesis, and the Elizarov methodology. And the increasing publication and awareness in the medical field about the topic of the induced membrane has encouraged us in the past 7 years to start our own series, Reconstructing Bone Defect by the muscular technique. The aim of this webinar is to present our experience in this technique and our misfortunes, and to highlight the proper technique and the causes of failure. The objective of this webinar to recognize the proper technique of induced membrane technique, highlight the causes of failure, and list the salvage options and the available alternative techniques. We are going to discuss 4 cases if we have time. Case 1 will answer the following questions: how to ensure infection eradication, proper cementation, cement implantation, recognize the graft choice and preparation. Case 2 is how to choose the fixation strategy and how to protect the membrane during the second stage. Case 3 will tell us how to increase the graft volume and avoid graft resorption. And finally, case 4 will discuss an alternative strategy. Now I hand over to my colleague, Dr. Mohammed Odd, to present the first case. Share screen, ya Odd.
Thanks, Dr. Mahran. Thanks, Dr. Mahran. Hello, everybody. I am Mohammed Odd, lecturer of orthopedic surgery in Shams University. I would like to thank Professor Amr for inviting me to share this case with you tonight. Also, I would like to welcome my professors, Professor Salah Abu Saif, Professor Mu'taz Fuad, and Professor Mahmoud Nahran, and to welcome the guests, Professor Trampus and Professor Christine. Today, I will present our first case regarding infection recurrence in induced membrane technique. Our objectives is how to ensure infection eradication and highlight tips for proper cementation and cement implantation.
في حد عنده همهمه يا جماعه يا ريت يعمل ميوت عنده لو سمحتم.
Highlight tips for proper cementation and cement implantation and recognize graft choices and preparation. Our first case is a 56 years old male with infected non-united fractured femur over an anatomical plate done 6 months ago, now presented with a sinus and purulent discharge.
Okay. Christina, are you on? Please unmute yourself.
Yes.
It's nice to have you tonight.
Thank you. It's an honor.
Sorry for keeping you that late.
No problem.
Well, in this case, Christina, I need to ask you, what will be your management priorities and what will be your reconstructive strategy, your preferable reconstructive strategies in these cases?
Well, we are absolutely sure that this non-union is infected because we have the sinus drainage. It would be interesting to try to find out which pathogen we have. And then I have two goals of treatment. We have to manage to stabilize the bone and treat the fracture, but we also have to treat the infection. And I think this needs a two-stage procedure. You have, if you debride, you will probably have a very large bone defect in the metaphyseal area. And you have to decide on how to best treat it after doing the debridement. You will have to probably remove all of the implanted hardware and then decide on which technique to use for reconstruction. And since it's a two-stage technique, I think this is a good case probably for induced membrane technique, although you could also alternatively do a bone transport.
So when do you decide these strategies? Do you always share with the patient the choice of choosing either ways?
I usually choose the choice with the patient. I tell them the advantages and benefits of each technique. Usually bone transport for them, it's a longer time with the external fixator, etc., but it's less complicated surgeries. With the Masquelet technique, you have two large surgeries. You have the debridement and removal of all the implant, cleaning all of the bone. And then in the second stage, it's a large surgery again.
Okay. And if you decide to do the Masquelet technique, and you will, of course, obtain cultures during debridement, what if you couldn't identify the organism? Would you proceed to continue for the Masquelet technique, or you would shift to the bone transport?
If I were to, I always do treat Masquelet as if you were doing a two-stage revision of an arthroplasty. So you sometimes have culture negative arthroplasties, but you know clearly that they are infected anyways. And I would consult with my infectious disease colleagues and see what antibiotic strategy to use. And I would always take some samples in the second surgery. And I would also consider if I had done something wrong to not be able to achieve good cultures. Maybe the tissues that I said were wrong. Maybe the patient was under antibiotic pressure. Maybe I can use other techniques like sonication that could yield better results.
Okay. Continue with the case, Dr. Odd.
Yes, sir. Yes, Dr. Mahran. So debridement and external fixation was done. Cultures were taken, but unfortunately showed no growth. So patient received the broad spectrum antibiotic combination, which was cefazolin and levofloxacin, until ESR, CRP, and white blood cells were normalized for 6 weeks.
Okay, okay. Andre, our dear friend Andre.
Hello.
Hi, Andre. Nice to have you around.
Thank you.
Again, Andre, we are repeating our main concerns that we have raised in the previous webinar. Negative cultures. Negative cultures are something that bothers us and put us in a place where we simply work blindly. So I need you in a nutshell to tell us what can the surgeon do in a nutshell from his side to avoid having negative cultures.
It's really surprising that in this case, which is clearly infected, that there is no growth. And as Christina mentioned, one reason could be the patient received antibiotics. It seems not the case in this patient, but I would definitely look not to give antibiotics before surgery. Second, several tissue samples are important. I don't know if these parts which are here were sent to the microbiology, but definitely it would be good to send enough different tissue. And the third, if in the lab, they cultivated it for 14 days in order to find these even slow-growing bacteria. But if there is, let's say, culture negative infection, then we still can have very good results with a broad spectrum antibiotic. In this case was cefazolin covering all the gram positives and levofloxacin, the gram negatives. I think it's a good choice as an empiric antibiotic. Yeah.
Okay. Christina, would you settle down for normal ESR and CRP to guarantee that you have eradicated infection? Would that be enough for you?
It wouldn't be the only. I wouldn't trust singly or only on right ESR, CRP, and white blood cell count. I would also trust the way the wound is evolving. If the wound is healed, the local symptoms of infection, pain, especially on percussion, or what the patient relates. And also, if you stop antibiotics before the surgery, it really gives you a sense if there is some sort of infection, and I would always culture second stage.
And you stop antibiotics 2 weeks.
And I know Dr. Trampus doesn't always do it. In my hospital, it is the protocol, and it helps me also trust that the infection is healed. It's not to increase the yield of the cultures. It's because usually clinically, the patient after 7 or 10 days will say, I have more pain. It's very common.
Mahmoud, I have comment, please.
Yes, Dr. Salah.
First of all, I again and I repeat the welcome for our colleagues and our guests, and we wish a rapid recovery for our professor, Dr. Ali. We miss him actually this night. Just I have one comment about the ESR and CRP to be sure the infection is controlled. If the patient has sinus, this is a fault because the sinus will discharge all out, and you may be misleading by the ESR and C-reactive protein. White disease maybe, yes, you can judge, but ESR, CRP, you have to be sure there is no charging sinus in this patient. If there is charging sinus, I cannot rely on this result to sure the infection is
Dr. Salah, I think you have a problem with your voice.
Change into 4G يا صلاح لو سمعنا please.
اوكي انت سمعت لغايه فين؟
ان انت will not rely لو في sinus. اوكي اتفضل.
انا I want to say if I have charging sinus, I cannot rely on ECR and CRP to be sure the infection is eradicated. This is only for closed wounds, but open wound, no, this is not an indication. We have to check for another signs of infection, another signs for to indicate the infection. White disease is okay, but this other lab, no, I cannot rely.
Okay. Okay, next, Dr. Ott.
Next, Yod.
Then antibiotics were stopped for 2 weeks. At 8th week, conversion to internal fixation was done with antibiotic cement spacer. No cultures were taken at this stage, and patients were on post-operative antibiotic, which was CFP. Labs CRP initially increased and then started to decrease gradually.
Okay, so I think the strategy on this case was a little bit cautious. The surgeon have decided that he will not put cement in the first stage. He just put external fixator, and he put cement when he decided to convert to internal fixation. He didn't want to put cement maybe in the first stage so as to avoid masking of infection. And at this stage, you said that you had no cultures at this stage.
No
What do you think? Andre, would you agree in not having cultures at this stage? Do we have enough evidence to guarantee infection eradication that we don't take cultures at this stage?
I think we should take cultures at this stage, but if they are negative, same as the previous, at the time of first revision, they were negative, it doesn't prove that you are infection-free. So I would treat also after internal fixation with antibiotics, just to eradicate the bacteria which still may be there. And actually, in this case, it was even started with an antibiotic. But after the intravenous phase, I would definitely continue with oral antibiotics, despite the cultures were either not taken or they would be negative. But I would always suggest to take the cultures. Unfortunately, the sensitivity is not very good, even if you stop 2 weeks of antibiotics, because you cannot really take it from so many places. You're random taking the cultures, and you have nothing for sonication. So they would be probably negative, false negative.
Okay.
I have a question.
Yes, Christine.
You decided to use antibiotic cement spacer?
Yes.
With antibiotics, and why the decision to add antibiotics?
Antibiotics were gentamicin and vancomycin on the cement. Why we decided to add antibiotic? It's
the known solution
to eradicate infection.
Can I have a comment, Mahmoud?
تفضل دكتور صلاح.
Sometimes even the organism is not sensitive to the antibiotic. If we put it in a high concentration in the local, it will overcome the sensitivity. What I mean, if the organism is not sensitive to gentamicin or the vancomycin, but I put it in a concentration high local, this will affect the local organism. So we use it as routinely. It is for to cover most of organism. Even the culture show it is not sensitive to it.
What's your opinion, Christine?
Christina, would you have done things differently?
No, I personally also add antibiotics generally. Also, I would have used the same combination. I know Mascalet has been proposing not adding antibiotics, and there are some authors that also not add. That's why I think it's an area of discussion, but personally, I always add antibiotics. For several reasons also to increase the porosity of the cement. And I personally would have used a different technique to create the spacer. I think it looks like you created it on
we will come we will go to this point, but your preference is still to add antibiotic,
Yes.
and your reason for that is to help eradicate infection and suppress
exactly
residual.
the same argument you had. It's
Yes.
a local deposit of antibiotics. It has
Yes.
very high concentrations that are even above the systemic minimum inhibitory concentrations. And also the antibiotic is eluted only from the outer millimeter. It's not like granules, like when you put in a bead, we call it a rosary. Of the bead of antibiotics. This is a solid block, and it only elutes from like the outside millimeter. So you don't elute all of the antibiotic you add to the cement.
Okay, so but you don't prefer beads. You don't
I
prefer.
don't prefer beads because with masquelet you also are trying to elicit a biological response, which is this reactive membrane to the block of cement itself.
Yeah. Okay. Dr.
Before
Salah.
leaving this point, Mahmoud,
I
want to say, Dr. Salah, before leaving this point, for those who didn't attend the previous webinar, Dr. Andre and Professor Christina, do you insist on having an extended culture, or you feel it is not important? I know that here there is no culture at all, but when you have a culture, you insist on the lab to have an extended one?
Yes, this is very important to always, when you either take it from the prosthesis or the bone or osteosynthesis, to ask for 14 days of incubation. Half of the bacteria grow after 1 week, between day 7 and day 14. So definitely, if you use only 5 or 7 days, you will miss at least half of the bacteria.
Yes, I do the same if it's, I know that the patient is infected because the patient had a sinus fistula and purulence and everything. So I know it's infected, and they always do an extended medium of up to 2 weeks in my hospital.
Okay. Andre, I had an argument with a microbiologist because somewhere where I work, when I ask for extended culture, they don't do it for me. And when I argue with the microbiologist, she tells me that if I keep the culture more than 3 days, usually what I get is contamination from the lab. Yeah. From the lab. So how much is this statement true? And if it's true, how to protect your sample from contamination in the lab, from the outside environment? Do you have an answer for that?
Yes, it's a good point that the longer you incubate, the more likely is the contamination. So if you would cultivate them for several months, all samples will be contaminated, because whenever you open the plate, bacteria from the air can contaminate it. But we will take not one sample, we take typically 3 or 4 or 5. And then you can easily distinguish what is contamination, if it's only one positive, and what is real. If you find it in the majority, so 2 or more positives of 5, then you can be sure that this is coming from the patient and not from the lab.
Okay. Dr. Salah, I need your comment, Dr. Salah, about the cement spacer. What would you have to say? What do you think about the spacer?
Actually, I just want to comment about the antibiotic who added to the cement. It is a balance between to keep the porosity and also to put the concentration not affecting the new osteogenesis. So actually we use about 2 grams for every bags of bone cement. We can allow it to use up to 4 grams. This can be safe and give us a high local tissue concentration, but not more than that. This can keep the porosity and give us the desired effect on the local tissues. What's your question, Mahmoud?
What about fashioning this spacer? What do you think about the properties of this spacer? Will it help the technique?
Yeah, it's better to put it in multiple cylindricals, not in one box like this. Actually, also
this was two cylinders, Dr. Salah.
Yes, but has no proximal collars, no distal collars. Yes, I think also it is not preferable to put it in touch with the metal because this will make a defect in the incoming membrane. Yes, it has many defects in the cementing procedure.
Okay, what else, Christina, can you see in this cement?
I think the cement is not filling the entire defect. It looks like the cement was prepared outside the field on the table, like measured, and you make a roll and then you put it in when it's hardened. I personally do not use that technique. I use a different technique that fills the entire defect and can also, in the end, you can add the collar that Professor Salah mentioned. I use a 50 milliliter syringe and I cut off the ends and I slice it open in the middle, and then I put it on the medial side of the femur, so that way I would have the artery protected, and I would have a sort of cylindrical U shape that I would fill in, and inserting a little bit of cement into each of the ends of the bone marrow, and then I would be able to collar it on each side, and it would be reasonably stable to heal in that phase. I use the cement I insert it by hand when it's sticky. I usually use the cement that we would use at the same consistency for knee arthroplasty. So that you mold it, but it won't, run away or anything.
And aren't you concerned about the exothermic reaction?
I think the exothermic reaction is also something that will help us because we want to induce some sort of tissue reaction. I think any microorganism that might still remain in the bone ends the philosophy is almost the same as when you have a giant cell tumor and that you fill it with cement, that the bone doesn't actually die from it. You only do a small necrosis of the outer millimeter of the tissue. In the second stage, when you fill it with graft and you re-ream the ends and you do all of everything so that blood comes back into that area, that having that millimeter of necrosis won't change that much.
Okay. Okay, thank you for that. Andre.
معتز معلش مهران دكتور معتز, I want your opinion, please. Do you believe in the original masculae without any antibiotics, or you believe on the same policy of adding antibiotics to the cement?
Personally, me.
Yes. I think I agree on putting antibiotic with the cement. Also, sometimes I like in this case when I choose to put an internal fixation, I combined it with calcium phosphate loaded antibiotics. It's not only loaded on the cement. So it's absorbable. It gives us some tissue penetration of the antibiotic, but according to the culture. If we have no growth, we still need to do another culture before deciding to put internal fixation really. One stage conversion to internal fixation without having organism is really risky, I think.
So you wouldn't use internal fixation at this stage, Dr. Mu'taz?
No, I will not use internal fixation in this stage, especially with no cultures.
Okay. What about you, Christina? Would you keep the original fixator?
I would like to thank Mu'taz for joining us because he's today on AstraZeneca and he's feverish and he insisted to join our webinar. Thank you, Dr. Mu'taz. Go ahead,
yes. Christina, would you keep the original external fixator rather than converting this to internal fixation?
I usually do masculae with a multiplanar external fixator when I insert the cement. I don't enjoy having to redebride and reculture and keep the plate that I had in the first stage. Mm-hmm. It's like doing a two-stage arthroplasty exchange, but leaving in the acetabulum from the initial surgery.
Okay. Okay.
It's the same. It's something I don't trust that much. I know people do it, and I know people go well with it. But this case, for example, I would have probably done a hybrid external fixator.
So, what kind of fixator would you use in this defect?
Probably the patient. The distal femur is small to be with a monolateral external fixator for very long because you already had internal fixation there. You already had a monolateral fixation. So I'd probably do a hybrid system with a 3/4 ring in the distal articular segment, and that I would bridge with a monolateral tube in a triangular fashion to the diaphyseal segment.
Okay. Okay, Andre, I need to ask you a question that I forgot to ask you the previous webinar. Is there any other antibiotics rather than the tobramycin, vancomycin, and garamycin that can be added to cement that is under investigations maybe?
The combination vancomycin and gentamicin is a very good combination because it covers almost all bacteria, including the resistant ones. Because as it was mentioned before, we reach 1,000 times higher concentration locally than we usually can reach if you give it intravenously. So that's actually my favorite combination, vancomycin and gentamicin. You can indeed add, if you want, other antibiotics in the pocket guide, which can be downloaded from the ProImplant website for free. There is a table saying which antibiotics are thermostable because it needs to resist up to 60 degrees. And there are a couple of them you can add in addition. You can add even a third one or a fourth one to maximum. We say you can go even higher than 4 grams per 40 grams. Sometimes you go to 6 and some go even to 8 grams of antibiotic per 40 grams. And this could be meropenem, this can be fosomycin, and can be also colistin if you have a really multi-resistant gram-negative.
Okay. What about dalacin C?
Dalacin is clindamycin. You can also add it, but we don't have it in powder. So basically, you should only use powder antibiotics to mix it in powder cement.
But you can have it in capsules. There is a powder in the capsule form. Can you add?
I think Andre has the same problem or opposite problem as I have in Spain. I have clindamycin in powder, and it's called dalacin in Spain, but I don't have gentamicin in powder.
Okay.
So I have the opposite problem. In order to add gentamicin, I have to ask the pharmacist to evaporate the fluid, and he gives it to me in powder form. And for dalacin, it's a lot easier.
But dalacin, we should not use in the capsules because this is it sterile? Yeah, it must be sterile.
Yeah, it is sterile.
Okay, so that's a good idea. Actually, I didn't think about that. Yes, very good idea.
Yes, we open the oral capsule and empty it in the cement powder. But I'm wondering if this has been studied before. I don't know.
I'm not sure if this dalacin is a pure substance or if there is any additive, but I can also have a check on that.
Okay. Okay.
You believe, Andrew? You believe? Sorry.
Yeah.
Go ahead, Christine.
Personally, to cement on top of the pocket guide, I have had experience with adding other antibiotics, but I only do it directed, which means, for example, to add colistin or something, it has to be in response to some cultures that we previously have. Then we direct the local antibiotics that we want to use to treat. And I have used, for example, meropenem.
What about rifampin? You believe in rifampin in gram-negative? Andrew, I know he's believing Rimactam or rifampin.
I haven't used rifampin personally. I think Andre Champus must have a better opinion than I. But we have used amphotericin B for fungal infections, and I have also used metronidazole for anaerobic for Bacteroides osteomyelitis.
With the cement, you mean, Christina?
Yes.
Yes, but we can't. I guess we can't add rifampicin to cement, right, Andre?
No,
I don't think so.
We cannot, because first it prevents polymerization, so it will not harden, and second, it will create resistance. So rifampin, Rimactan, or whatever is the name, should be used only orally, not locally.
Okay. Let's see what happened next, Dr. Odb.
So 8 weeks later, second stage was done.
I think you have a problem. You have a problem.
Bone block and ipsilateral fibula.
You have problem with your voice. You have problem.
Okay.
Could you repeat that again?
Okay, he's now.
Do you hear me, Dr. Maran?
Yes, yes.
Yes, yes, go ahead.
Oval of the spacer and iliac crest bone block and ipsilateral fibula. And also no cultures were taken and patient received antibiotics for 48 hours only.
Okay. My question now is for Andre. Again, Andre, repeating the same question again. What is the role of intraoperative frozen sections? You know that we wish that we have a way to confirm that our debridement is adequate and our field is totally infection-free before we graft. So we have some papers speaking about taking histopathology intraoperatively. I need you to comment on that, please. Frozen sections.
Frozen sections at this stage are not necessary because they will show some kind of inflammation due to healing process. So I think cultures, but not for histology. Histology is very good at the first surgery when we want to know is it infection or not, but not at the revision surgery. What I like is your procedure, I must say, from infectious disease standpoint. So that's a 3-stage procedure with, I think, a very good choice for the infection. The only thing I would suggest different is to prolong the antibiotics after this 48 hours as an oral antibiotic.
But I guess the surgeon assumed that infection has been eradicated. That's why he put a graft. So he did only prophylaxis, routine prophylaxis for as any clean surgery, not going beyond 48 hours. But would you recommend to go longer in these cases?
Yeah, I would definitely recommend longer because whenever you put another foreign body inside, theoretically, one bacteria is enough to again start all the problem. So that's actually the best point where you can give antibiotics after the wound is closed in an oral form. And this would definitely improve your success from, let's say, 60 to 70% to 90%. And it can be cotrimoxazole. And if you can, at this stage, I would go also for rifampin. Or rifampicin, because most likely pathogen is staphylococcus.
Okay, Christina, wouldn't you prefer to remove the cement, take cultures, and wait? If the cultures are negative, you graft. If not, you put the cement again. Or would you go with the same technique, removing the cement and grafting immediately?
So you're asking if I would have gone for example, for a 4-stage procedure?
Yes. What's your preference?
Well, you already have the negative. Well, you didn't take any culture samples in the 2nd stage, but assuming if you had taken cultures in the 2nd stage, I think it would be, and it was negative and no signs of infection, I think it would be sufficient to do a 3-stage procedure. I don't think you win much by doing a 4-stage procedure because you also increase the risk of adding new infections in each surgery.
Yeah, but if you take culture at this stage, you will have to wait for 2 weeks to get the culture. But so how do you decide the timing of grafting?
I insert the graft and I assume and I treat as if it were infected, which means I start empiric antibiotics, as Dr. Trampos has said, and I continue them at least until I have negative cultures. If they are positive, then it's as if you had done a 1-stage exchange procedure in which you think, for example, and it's an arthroplasty and you do a revision, and in the 2nd stage you find positive cultures and you decide to treat as if it were infected.
Okay.
You try to avoid the forming of new biofilm. The disadvantage with finding the new cultures is that since you already have the plate inserted, that plate already, and you haven't changed it because you've maintained that internal fixation, that plate is already covered in biofilm.
So would you change the plate?
I always try to exchange the internal fixation I use for each additional stage.
Okay. Dr. Mu'taz Fouad.
Yes.
Dr. Mu'taz, what do you think of the graft choice? We have an iliac crest bone block, and we have a fibula that is outside the membrane. What's your comment on that?
I think what we need in such a defect, we need stabilization and we need cancellous bone graft. It should be morselized, not all en bloc. There is no difference of using this iliac crest en bloc and a fibular graft en bloc. They are both the same. We didn't add any cells for healing. So I think you can use the fibular graft, put it maybe centrally a little bit to give some stability, and use the cancellous graft, cancellous bone graft, morselized to fill around the defect proximally and distally.
Okay. Okay, Dr. Odd could continue, please.
Yes. At the 14th week, patient was presented to us with recurrence of infection and the sinus discharging pus, unfortunately.
Continue.
Patient then refused any other salvage procedures after debridement. I did debridement, but infection recurred, and the patient refused any other salvage procedures, and above knee amputation was done elsewhere.
Okay, Dr. Odd.
So what went wrong? The main two issues is that infection was not eradicated to imply induced membrane, and induced membrane technique was not applied properly. The absence of infection control is the single most frequent cause of failure. It can be the result of insufficient debridement or an inappropriate antibiotic medication. Induced membrane technique can be deployed only once infection is definitively eradicated or at least brought under control. Timing of second stage. Induced membrane aged up to 14 months contained mesenchymal cells with osteogenic potential. Waiting longer between the two stages does not delay the bone union. So in infected cases where lab parameters slowly decrease, waiting more than 6 weeks for grafting doesn't seem to be a problem. In this series included 21 infected cases underwent induced membrane technique. Debridement was done with culture samples and antibiotic cement spacer with external fixation, and patients received broad spectrum antibiotics till culture results appear. Then the patients received culture specific antibiotics for 6 to 8 weeks or when serum marker normalizes. Then the patients were reoperated with pin-side debridement and irrigation with removal of the cement spacer with visual inspection of tissues and culture samples again. Suspicious tissues was redebrided and cultures were taken, and if in doubt, repeat the first stage. Then patient received antibiotics if the cultures are positive again. So the safe approach is the staged reconstruction protocol, which consists of at least 3 stages. Stage 1 is radical debridement, antibiotic-loaded cement spacer, and temporary external fixation. And depending on the post-operative debridement culture, either proceed to second stage or repeat the first stage. A second stage is a secondary debridement, antibiotic-loaded cement spacer insertion, and definitive internal fixation. And again, according to the cultures and ESR-CRP, either repeat the second stage or proceed to third stage, which is cement spacer removal with or without augmenting fixation and autogenous bone grafting. So to summarize, tips to avoid infection recurrence is external fixation in first stage is preferred to internal fixation. Several cultures must be taken in each stage of the procedure. Don't hesitate to repeat debridement at any stage if in doubt that infection is not cured. And don't rush for grafting and wait until labs are normalized and the infection is resolved. Graft choice. Bone block is suitable because it will not be revascularized, is not suitable because it will not be revascularized by the membrane. Cancellous bone graft must be shaped in a little cubes of 1 millimeter. Morselized cancellous bone graft must be shaped in a little cubes of 1 millimeter, which aids revascularization. Adding a strut fibula to the graft inside the membrane is advantageous in the femur, especially in distal defects where a plate is used. The divergence between mechanical and anatomical axes of the femur results in a high varus loads, which jeopardize graft corticalization in case of insufficient fixation. Thank you.
Dr. Amr Khairi, do you have any comment before we shift to the second case?
No, I just was to ask Christine about she's have any modification on this protocol, or she agreed with every all the stages mentioned in the protocol. The Spanish school, I mean.
The Spanish school. Usually, I don't always do it 3 stages. I sometimes do 2 stages, and I only do the definitive internal fixation when I am absolutely sure it is culture negative. So if I find a culture positive and with internal fixation, I would also exchange that internal fixation, especially if it is a nail.
Yes, dear. Thank you.
Okay. Okay. Now we have yes, Andre.
Just a short comment. I agree that maybe change of the plate. Was it right? The plate was not changed, right?
Yes, it was not changed.
Yeah, I think bacteria, the question is where the bacteria persist, maybe in the bone, maybe on the plate. So changing the plate would be maybe a good idea as one comment. And the second, maybe we could prevent this relapse by giving antibiotics afterwards. Because even that you take cultures and they are negative, it doesn't really mean that it's really negative because they're not so sensitive. So I would, in any case, if you take cultures or not so much rely on positivity or negativity, but I would always give antibiotics after the 3rd stage and continue for either 6 weeks or even 12 weeks if the cultures would be positive. That, I think, could improve the outcome and prevent relapse.
Also,
thank you for
another point I would like to say.
Yes.
One of the missed opportunities of not taking cultures in the final stage is that you do not know if it is a persistence of infection or if it's a newly acquired infection of a major surgery in which you have used a lot of structural graft and that has a very common and high complication rate by itself. So you could be in face of a new acute infection or a persistence of the chronic infection. You will never know what you're actually treating.
Yes, I totally agree
Good
with
point.
that. Good
Very
point.
good point.
Dr. Mu'taz, one last question for you. I know your insights and opinion, but Dr. Mu'taz, would you prefer to proceed for the second stage with internal fixation, or do you have preference with external fixation? I think using definitive external fixation would have saved us a lot of hassles. What do you think, Dr. Mu'taz?
Mahmoud, I'm an external fixator man. So I do not use internal fixation for these kind of problems. Maybe I preserve this internal fixation for the aseptic bone defects. But if we have sepsis, maybe long-standing, something like this, 6 months or more, I do shift to external fixators, definitely.
Especially when you have a negative culture.
Yes. Culture, you can have always negative culture. You can have always CRP normal, CBC normal, ESR normal, but infection is there.
Yes, I totally agree with that. Okay, we'll shift to the second case. We have
50 minutes دلوقتي
لا
in one candidate.
ما هو دي هي المين كيس يا دكتور عمرو والباقي هيمشي بسرعة إن شاء الله. I hand over to my colleague, my brilliant colleague Ahmed Mansour for presenting the second case. Share screen, Ahmed.
Hello, everyone, and good evening. It's an honor to be here. Distinguished guests, we're going to try to run through this as quickly as possible. In this case, the objectives are we're going to try to know how to choose the fixation strategy in our treatment plan and how to protect the membrane during the second stage. This is a case of a 34-year-old male patient who had a closed fracture 2 years ago, was treated by internal fixation, He had a history of prolonged post-operative discharge, and which was suppressed by empirical antibiotics for a long time. And he presented to us with this clinical picture with an exposed plate and obviously infected bone.
Yes, sir. Continue, please.
Okay. Our management was, we're going to go for a emasculate technique and two-stage technique. So we started off by debridement and sequestrectomy and removal of all infected soft tissue that was visible to us. We applied an X-fix and we put an antibiotic-loaded cement spacer. We also added, our friends from the plastic surgery had a myocutaneous flap, which was taken quite good. And 6 weeks later, after the graft was taken and skin was healed properly, we went for our second stage of management.
Okay, I might stop you here, Dr. Ahmed. Dr. Salah. Dr. Salah, please. Dr. Salah, do you agree with the initial fixation strategy? What do you think of the kind of fixation that we had at this stage?
Look, at first stage, we don't need an absolute stability. This fixator is more than enough just to keep the position and to maintain the length. I think as a first stage is okay, but this not to be suitable to continue for second stage.
Okay, why don't you choose a simpler form, not putting only a slap at this stage, Dr. Salah, to avoid pin tract infection?
We accepting some relative instability, but not total instability. If we put the cement will be extruded about the space, and you cannot control the bone. This simple frame external fixator will be more than enough for this first stage, just the cement stage. But you have to think about other type of fixation when you shift to the second stage.
Okay, Dr. Ahmed Mansour, if you run back in time and you have to do this case again, do you have would you done anything differently to this cement spacer? Do you have any comment?
Yes, I would. The cement spacer, as you can all see, concerning its width, it was okay. It's a little bit wider than the bone, which is a good thing, but it's not as long enough. It should have covered the bone ends with a collar, which would allow the membrane to more or less overlap the bone and to give it strength. And that's about it. But
okay.
Other than that, I would go the same.
And no cultures were obtained at this stage?
There were, no, we took cultures and it was negative as usual.
As usual. Okay. Proceed, Dr. Ahmed.
So 6 weeks later, after we said that the skin was taken, graft was taken, we went for removal of the bone cement spacer with a longitudinal incision to the membrane, as you can all see, and we removed the cement.
Okay. Hold on, Dr. Ahmed. I have a question for Christina. Please, Christina.
Yes.
Would you wait exactly for 6 weeks, 6 to 8 weeks, as implied by Musculae, or you would wait more time? Sometimes that you have at the 5th week or the 6th week, you have still the lab parameters are high, but they are still decreasing. Would you go for the second stage at 6 weeks exactly, or you can wait longer?
I have no problems with waiting longer. I think it's actually the majority of my cases, because I have, as it is in many public health systems, sometimes have difficulties programming because of waiting lists and other traumas that are more important. And in the instance, these are usually complex, relatively complicated surgeries that you can't just squeeze in. Sometimes they have to wait 8 or 6, or now with COVID, I have a few that are going on a year. I have to see how that's going to go. The lab parameters, there are also patients that have, for example, other diseases where they won't normalize. If you have a patient with rheumatoid arthritis, it's not exactly the only parameter you can't, if you see it goes slowly down and maybe even just plateaus at a level that for the patient is maybe that normal value. If the soft tissues are okay, and I think that's the most important thing, to look at the wound. If the wound is okay and the patient is symptom-free, I think then you can be pretty sure that that is going well. And I always also sample the second surgery.
Also, you have many patients that waited more than 8 and 10 and 12 weeks, and you proceeded for the second stage with no problem.
With no problem.
Okay. Dr. Salah.
I have a comment, please.
Yes, Dr. Mumtaz.
Dr. Christina, you will be astonished when you open this after a long period, year or months. You will find mature osteoid tissue. Maybe it's not ossified, but you will not find membrane. You will find osteoid tissue all over the cement spacer. And then sometimes when I open and to remove it, I get asking myself, why do I open it? Why I didn't leave it like this? It's already healed, no infection. So can we leave it forever? Can we leave it there forever?
In my case, the 2 cases that I have that are waiting are foot infections. And the masculae was a initial stage for preparing for doing an arthrodesis. 2 cases of subtalar arthrodesis with osteomyelitis with a big bone defect of the calcaneus following a calcaneal fracture. So I'll have to fill in and achieve arthrodesis probably anyways. So I have to see how that's going. I just ordered X-rays on one patient that I hope I will be able to operate next month. I'll tell you.
Okay, thank you.
Okay.
Dr. Mumtaz, I want to understand what you said. You mean that the membrane goes into ossification?
Yes, it goes to ossification, osteoid tissue.
So why shall I change everything? I will leave everything as it is.
That's what
the patient is well bearing on it.
Yes, that's what I am asking myself. Why I
like in the giant cell tumor.
Yes.
In giant cell tumor, you put cement and leave the patient.
Yes.
But if you are on external fixator, you are obliged to change this. You cannot be forever in external fixator. And also, if you remove the external fixator, you cannot rely on putting him on a brace for long period. So if this technique was done with internal fixation, it will be very good if you can keep this cement after a long period, no problem, no infection. Why not to leave it?
And put
I have a comment, Mahmoud.
Yes.
Dr. Salah.
Actually, if even the membrane is ossified, it is not enough union to rely on. The membrane itself, even it is ossified, this is not an union. You cannot even leave it for a long time. What then? The patient cannot repair on this. It will be on cement. No, even take it long time.
I think Dr. Mumtaz didn't mean that, Dr. Salah. But maybe this is a preparation to discuss his technique. But we are saying that the longer you leave the membrane, this is not a disadvantage. If you have a delayed referral of the patient to the second stage, this doesn't mean you cannot complete the
yes, but for a long time. Yeah,
of course.
No end.
But if you have, yes, they noticed this when the patients were missed. So we want to make use of this observation.
I think there's a large difference between 6 weeks and, for example, what I'm talking about now with COVID, which is going on to 60 weeks. So that's 10 times as much. I think 60 weeks is not the ideal, but of course we have a different health situation right now. But I have done cases with 8 or 10 or 12 weeks very well without any problems. And with external fixation for that time, if the pins are okay and the patient tolerates it well, it gives you a good feeling on how the case is going. And if you can't program it 1 week and you do it the next week, it doesn't matter.
Okay. Okay, Dr. Mansour, proceed, please.
I just want to mention, in our case, as Dr. Christina had mentioned, we had our normal lab parameters and we did not have any loosening around the pins. Clinically, there was no signs of infection that we saw visualized. So that's why we went for, at the optimum time was 6 weeks when we found that everything was fine. So let's go and not delay. Anyway, so going on, we took a fibular graft from the same leg, ipsilateral, and inserted into the membrane and closed the membrane properly with sutures to ensure that the membrane chamber is closed properly.
Yes.
We added an Ilizarov external fixator as a definite fixation for our patient. And as you can see, we went for a very rigid frame as much as we can. We added a lot of pins and wires, so the frame would be extremely rigid to allow vascularization of the graft, and for the patient to start weight bearing at pain tolerated and gradually increase by time.
Okay, hold on, Dr. Mansour. Dr. Mu'taz Fouad. Dr. Mu'taz,
Yes.
we are all external fixators, guys. We face many problems doing bone transport for longer period. Do you think there was an advantage of adding a static frame for a muscle second stage? And is it different clinically regarding the patient compliance and comfort than doing a bone transport frame? What do you think about that, Dr. Mu'taz? Did it add any advantage?
That's what we are working on now, Mahmoud. Either to go for a graft or to go for bone transport through the membrane. That's our new strategy. We are trying to make some comparative study between these cases. We will see. Maybe it will take another year for to have the results, the full results. But as for now, this seem okay. No problem about making a static frame and waiting for healing, especially when you have no infection, you have a very good membrane, and you put your graft and the cancellous bone graft. I think it will be okay.
Mansour, do you have something to add? We all face difficulties.
Before Mansour, please. For my mind, I'm not an X-fix man, but I'm asking ipsilateral fibula or contralateral fibula. I need instability. I know that you have done an. I think what are going to choose, Dr. Salah, Dr. Mu'taz, and Christina? What are they going to choose?
Can I answer, Dr. Amr?
Okay.
Ipsilateral is okay because the stability here is depending on this rigid frame. Also, I want to have some comment on this construct. Actually, we are going to experience a musculoskeletal knee. We have also to have a plan B. That's what Dr. Mansour did. He put an Ilizarov in a way he can transfer any time to bone transport. This construct allow him, if the muscle not successful, to shift to a bone transport with minor surgery or what's called no need to change the fixation. That we have to put in mind. We have also the musculae has to maybe failed at any time. The three-stage strategy is very long time, and it is time consuming, and the patient may drop at the middle. So we have also to keep in mind a plan B. That's what Dr. Mansour did, and I like this. He put the frame, he can shift to bone transport at any time.
Okay, just before letting Ahmed continue, Dr. Andre, just one side note. Andre, are you with us?
Yes.
Yes. We are all doing external fixator, and our main restricting thing is pin tract infection.
Mm-hmm.
So sometimes we have a stable frame and we know that the pins are stable and it's still pouring pus. Would obtain culture samples from the pins representative of the true infection, or what do you think about that? Or we treat this as a sinus, we don't culture?
I would indeed not suggest to culture the fluid from the pin tracks. It is usually outside of the fracture region in the lung, so once you remove the frame, this heals very well. Not backwards. So we just clean it, and with good antiseptics, that's enough. So it's not representative from what is inside.
Okay, but sometimes we have loose pins with ring sequestrum. Should we culture this sequestrum?
Yeah, if it's now loose or sequestrum, then you need to remove it. And not only the frame, but also the sequester. Sequester itself is not a good sample for culture. because the bacteria are probably inside of this dead bone, and there is no way to cultivate them. So we don't cultivate sequester neither. But you need anyway to refresh the bone. And if you can culture something from there, that would be more representative.
Thank you. Thank you for that.
I have something to answer.
Yes.
Dr. Champo.
Yeah.
I actually
Yes.
have found the opposite, that the sequester worked very well for culture in my hospital because it's bone that's very porous and it has a lot of biofilm because it's dead, and the bacteria make biofilm on it. And the microbiologists in my lab, they put it in a sort of blender and they culture it in fluid. And that has apparently very, very good, excellent results. I mean, first 24 hours, they usually can answer what we're talking about.
Yeah,
so
thank you,
experience.
Thank you, Christina. I think it's important to say not to put the sequester in the fluid, but you need to defragment the bone, not putting too much heat on it. So you said you have or your microbiologist has a blender. How does it look like?
I don't know. I think they crush it. It's something I can try to find out, but they make it a very small sample, very lysis.
You did a good point actually in the soft tissue also. If you take the sample in the lab, we homogenize it. So either by hand or with a blender, and probably the same is done by the bone. So that's a good.
Another comment on this case in particular regarding the fibular graft. In my hospital or my practice, the fibular graft is always my plan F. And once you go after plan A, plan B, plan C, plan D. And when I do fibular graft, it usually is with a plastic surgeon, and we do it vascularized. So I usually.
Was my second question. Yes, my dear.
Was it vascularized inside the membrane, Christina?
I have done that only on one occasion, and it was a femoral defect with in which we used the fibular graft to add stability in a double barrel fashion. But it was a combination, and the fibular graft wasn't exactly a graft only; it was also a strut. I also use a lot of cancellous graft because the membrane actually works doing an indirect union. It's actually the blood vessels going in from the periphery, from the sides, and you can see it very well on this X-ray that it's actually a metaplasia or whatever from the peripheral area of that membrane that is forming new bone. So if you pack that,
Dr. Mahran was asking Christina was asking you, it's a free vascular bone transposition, vascularized bone transposition. Just move the fibula to the tibia, or it is a free vascular graft.
I usually avoid doing direct bone transposition, because that means I don't have the fibula to do a free vascularized graft in the future if that fails.
Okay.
So the fibula is more last case. I understand that, for example, I was talking last week with a couple of you, and in my hospital we use RIA, reaming irrigation aspiration, and you actually get like a small teacup full of bone graft using the RIA system from the femoral canal, and you do not have that option. So
yes, we don't.
We have it a lot easier to get a lot of cancellous bone graft that would easily fill that defect.
Yeah, and the more problem is that sometimes we have patients, infected patients, that has graft taking from the iliac crest bilaterally. So sometimes we don't have a choice, I guess.
Yes.
I have comment, Mahmoud.
تفضل دكتور صلاح.
It is a good idea to take a vascularized fibular graft, but I think it will be so difficult in this infected case. The anatomy change, he has a local graft, the arterial anatomy is disturbed. And actually we are depending on the periphery of the membrane, not the center of the membrane. The vascularity and the healing come from the periphery. The central part sometimes even stay long time, even after union, not united or not taken. So I don't think it is so much beneficial to add a vascularized graft. I think the fibula head just to increase the volume of the graft, to give us some stability, but we are depending mainly on the bone graft at the periphery.
Okay, thank you for that, Dr. Salah. Continue, Mansour, please.
This is the patient's follow-up. As you can see, the graft was taken and healing started to appear on the X-ray. The patient disappeared for a while after the frame removal and showed up a year later with complete bone union and hypertrophy of the graft and very good functional outcome.
Continue, Mansour.
So, if we talk about, we try to criticize the use of external fixation in the first stage. The advantages, of course, of using an X-fix during the first stage is to prevent the formation of bacterial biofilm that could appear with the internal fixation, and this would lead to a decrease in infection recurrence. The disadvantage is, though, that due to the relative instability of the construct in the first stage, as we saw with just 2 pins, proximal 2 pins distal, this might lead to pin tract infection, joint stiffness, discomfort to the patient, and worst of all, cement extrusion. So the use of a definite X-fix during the second stage. In literature, we all know that if you want to convert an external fixator to an internal fixator in a single procedure, this should be done in less than 14 days of applying the X-fix at the beginning. More than 14 days, there's an increased incidence of infection. So, meaning that move the X-fix, wait for another couple of weeks, then remove the cement and apply an internal fixation with the graft. This could lead to loss of stability during this waiting period, which might lead to cement expulsion and subsequently disruption or injury to the membrane formed. There are other methods in literature of fixation during the first stage. Some reported very good results with the sequential internal fixation as they apply intramedullary wires to hold the bone with the cement, the proximal segment and distal segment of the bone with the cement to avoid the complications of the pin tract infection and X-fix, and allow as well, if there's any soft tissue damage for reconstruction by a plastic surgeon, they would have the freedom to work around the limb without the cumbersome of the frame. Another method for preparation of the cement spacer is the in vivo preparation, where they prepare the cement outside and cut it into segments and then apply it inside the gap with the collar. This avoids tight packing of cement and subsequently difficulty of removal later on. A debatable issue, which is avoid thermal bone necrosis, which we discussed in the first case. And this method with more than one layer of bone increases surface area for antibiotic elution. So, as we all know that the membrane is a very, very precious thing and we should always try to protect it. What if it's injured during cement removal or during the surgery? How to close this chamber again? We use the perimycium of the concept to allow the concept of fetal biological chamber around the bone graft. The contact stability. Contact stability in the early second stage after applying the graft, we need a very high, extremely stable construct to allow graft revascularization. Later on, a more flexible construct is allowed to enhance graft corticalization and remodeling.
And you could achieve this by applying a rigid fixation that can be dynamized later gradually. I think this is a good point in this case. What do you think, Dr. Ahmed?
I agree. Using X-fix like the Exothermic vein allows us to gradually dynamize as we go further in the management, removing pin by pin every once in a while to allow more dynamization and more loading on the graft after it is taken to allow remodeling and corticalization.
Okay, Christina, how can we dynamize in the presence of a plate?
That is very difficult.
Yes.
I think it's also a thing of concepts of the fixation that you want. I think generally, if you are using plates for masculate. I use plates with very long working arms. For example, that would cover in this case, the entire tibia. And at first, I would also probably complement with a slab, plaster slab. And then I would remove the plaster slab. I think the plate itself, if it's a locking construct, is inherently stable enough to be very rigid at first. And as soon as a patient starts bearing weight, I think it loosens a little bit. It allows for a little bit of, you can actually see it heals on the contralateral side in many fractures that you do with long working arms.
Okay, just one last question for you in this case.
I have just more comment, Mahmoud.
Another
Yes.
option, excuse me, another option, which I actually haven't used ever because you are a hospital of a lot of external fixation, and my hospital does a lot of external fixation, but we also do a lot of intramedullary. And I've done a lot of intramedullary fixation in masculate because what happens in the medullary canal in the inside actually doesn't matter, and that means you don't need to use that much graft in the second stage. But if you use two plates, you can actually use a more rigid construct with a mini plate on the contralateral side. And then in a second stage, if you want to dynamize it, you just remove the screws on one end of that mini plate.
Yeah, that's a good answer. I didn't expect this. That's a very good idea. Yes. Dr. Salah, did you want to add anything?
Just I want to clear some point about shifting from the external fixator of the first stage if you are planning to put an internal fixation of second stage. We cannot leave the patient 2 weeks without any fixation to be sure that the infection is clear. If after 6 weeks we are not sure that the infection is clear and we want to remove the fixator, to plan to put an internal fixation, we can change the pins. What I mean is if you are planning to put an internal fixation and after 6 weeks, you can change the pin and keep the fixator in another place, what I mean, and then within the 2 weeks, you can put the internal fixation.
Okay.
Another option with internal fixation, I do this for all my trauma cases, and I also do it for all of the cases I convert with masculate. I treat the pins, even if they look okay, as if they were infected, which means I over-drill the holes after removing the pins, and I wash them out.
We do that as well.
And up till now, I'll still try to keep lucky, but it hasn't been too much of an issue to have infection at the pin sites. I might have had, for example, in some cases, persistence of infection at the non-union site, but the pin tract site actually was never too much of an issue for me.
Okay, okay. Okay, Dr. Mustafa, we shift to our third case. Dr. Mustafa?
Thank you, Mansour.
Thank you.
Thank you, Dr. Mahran. Good evening, everyone. The objectives to the next case are first to discuss how to increase the graft volume, and second to discuss how to avoid the graft resorption. This is the case of a 30-year-old female patient. She had an infected non-united proximal femoral shaft fracture, and she had fixation by intramedullary nail for the past 6 months. She was presented with a sinus and a purulent discharge. During her first stage, the nail was removed. A 10 centimeter of the femoral segment was resected. This was followed by an application of the antibiotic cement spacing with application of a monolateral femoral fixture.
Okay, just a second, Mustafa. Dr. Mu'taz Fouad.
Yes.
Yes, what do you think of this fixation strategy? This is applying a definitive X-fix in the first stage. What do you think of that? Is it advantageous, Dr. Mu'taz?
I think in the first stage, we do not need to put all these pins because it is expected to have some of them loose by 6 weeks. So if it is preferable to put just in the distal clamp, put 1 or 2 pins and the middle clamp 1 pin. And in the most proximal one, just put 2 pins. You do not need all these pins. Some of them will invite infection and loosening.
Okay. But do you think it's advantageous to use an LRS temporary in this stage?
if you will use it the same, economically, we cannot change a fixator every 6 weeks. So if you have some economic problems, we can use the same external fixator and just changing the pins later.
Okay. Okay, Mustafa.
Okay, she had her second stage 7 weeks after the first stage. The membrane was carefully incised. The cement spacer was retrieved. A fibular strut graft was impacted into the femoral defect. The membrane was filled with the cancellous, with a morcellized cancellous iliac crest bone graft, and this graft was expanded by a calcium phosphate bone substitute. Finally, the membrane was carefully sealed.
Okay, Christina, what's your preferable graft expander?
I use a antibiotic-loaded calcium phosphate and sulfate mix, which is sold as Theramint. I do not get any royalties or anything. It's just I think the brand is Biocomposites. I'm not actually very sure.
Yes.
And that's the brand I use most. It's premixed with vancomycin or gentamicin. And but I use as little as possible and try to use as much cancellous bone graft as possible.
What's the ratio?
Maximum 3 parts bone, 1 part calcium phosphate. And if I need to expand cancellous bone, I use we have a bone bank with a donor bone.
GPM.
So
you use GPM or femoral heads?
Femoral head, probably. Tibial head.
Yes. Okay. That's beside the iliac crest bone graft.
That's beside the iliac crest bone graft, yes.
But when you use RHEA, you don't need actually an actual.
When I use RHEA, I get a whole entire glass of the RHEA is with a cup, and the entire cup fills with a femoral bone canal.
Okay. Okay.
You usually, if you really aggressively do RHEA, you don't do it. Usually, we don't need to get all of the graft we could get from a RHEA remix.
Really, that's interesting. So sometimes you have extra graft with the RHEA.
We usually avoid getting too much graft. We don't want to throw graft away.
Okay.
But we have actually had some cases where we have that much graft in the end that we can really pack it tightly into the membrane.
Okay. Dr. Mustafa Baraka, do you see any advantage of using the strut fibula in this scenario?
Yes, I guess in the femoral defects during the second stage, they have the mechanical advantage to overcome the volume mismatch or the load mismatch compared to the tibia because of the angle.
Does it have any biological? Does it have any biological advantage?
No, I guess the morcellized cancellous graft is superior for their superior osteogenicity compared to the fibular strut graft.
Dr. Salah, what do you think? Does it offer any biological advantage being put inside the medulla?
No, it is just biomechanically advantage, and also it's volume expansion just to fill the space and fill the membrane. And as Mustafa said, it also resists some virus or some stresses. But sometimes we found the membrane is fully solidified. And part is not. No, I think the center part is not important in muscular technique.
Yes, I agree with the volume expansion, because if you did not have that fibular graft in there, you would need a lot more cancellous graft. So you have two alternatives. You have the fibular graft. Some authors also use some sort of foreign body that reabsorbs, like hydrocolloid or gelatin sponges, etc. And you could also use a nail, and then you would need less graft in the end.
The same, yeah. No biological.
Dr. Mu'taz, if you had to use the fibula, would you put it on the medial cortex, Dr. Mu'taz, or you still prefer to use it centrally?
No, I still prefer to use it centrally, Maran, and put the other graft on the side.
Okay, proceed, Mustafa.
Those are the immediate post-operative X-rays directly after the second stage, showing the fibular graft and the cancellous graft. The proximal pins were also exchanged because of some loosening that we observed during her second stage.
Yes.
At 2 months, there was a good consolidation at the distal end, but we observed a substance of the fibular grafts down into the medulla of the distal fragment, of the distal femoral fragment. Also, we've noticed a decrease or resorption of the cancellous graft volume at the proximal end of the graft.
Dr. Mu'taz.
Yes.
What do you think has happened? If the surgeon hasn't already compressed the defect, what do you think has happened here? Do you suspect pin loosening proximally that has caused that subsidence?
No, I think this some compression was made by the frame. If this come from the pins, it will not be like 2 centimeters or something like this, or the pins would break through the bone.
Mm-hmm.
I think this is maybe the clamps were not tightened enough. Something went wrong. If it's not a direct instruction for the patient to do compression, maybe something went wrong with the clamps that was not tightened enough.
Dr. Salah, do you have any extra comment on what happened?
Yes, if you notice the last proximal pin, you see some fixation around the pin. This may be signs of low-grade infection. This will contribute to the non-union at this side. Also, I think that the site of this pin, I think, is not correct. It's better can be removed. This is not good. Maybe this fibula migrate to the due to some varus force added to the patient with bearing. If the patient with bearing, you got some varus force, you cannot notice in this view. But I think it has problem in the last proximal pin, has to be removed. It has a low-grade infection in the proximal part. I think this is the main problem.
Mustafa, do you have any explanation, Mustafa?
This substance of the fibular graft into the distal fragment was not intentional by the surgeon, but we have no explanation other than some loosening at the proximal pins with collapse of the length into the medulla of the distal fragment. This was not intentionally done by working on the distractor rod.
I have another comment, actually, or question.
Yes.
Because if you look at the distal part of the fibular graft and the cortical bone surrounding it, you see that the cortical bone does not have the same diameter.
Yes.
It looks as if it's like trying to have some sort of loosening around that fibular graft, because I think in the control X-ray you couldn't see that diameter difference of the cortex that well. And you also have to bear in mind that the patient initially had an intramedullary nail, so that cortical bone is actually closing. So I don't know if it's a stress effect of that cortex trying to close, or if it's a loosening, radiolucent line around the strut that it has a low-grade infection.
So we agree that we all suspect infection. We all suspect infection in this case, but there is nothing to do to make sure that except obtaining cultures. So let's see what happened next to Mustafa.
4 months, there was a good graft consolidation at the distal end of the graft, but we've noticed further resorption at the proximal end with radiolucencies surrounding the proximal end of the fibular graft.
Okay. Next.
Finally, we had to remove.
Please, Mahran, ask Professor Andrew if there is if the culture have role at this stage.
No, because you cannot really do the biopsy. No, either you do percutaneous or you do an open biopsy, but it's difficult to find bacteria. I think we have enough suspicion that this is an infection, so we can procedure to the surgery without doing diagnostic biopsy of the bone.
Okay. Okay, but Andre, do you recommend minimally invasive biopsy?
In bone, actually not.
Not. Okay.
It's so low sensitivity that the best is when you anyway do revision and therapeutically then you can do also diagnostic, but not only for diagnostic purposes. Christina, do you agree?
Yes, I don't do percutaneous biopsy ever. I do percutaneous aspiration if there is, for example, a collection of pus, stuff like that. And I do it guided by ultrasound or CT usually, but I don't do bone sampling. In my hospital, we do culture our tumors because some things that look like tumors wind up being infections. So at least one of the samples for tumors are always sent to, of the true cuts from the tumors are always sent to infections, and sometimes you have surprises.
I think in two situations, a preoperative biopsy or aspiration may be useful. One is what Christina, you said, if there is a fluid collection. Second is the joint itself, intra-articular. And maybe the third is the discus in the spine. This is what we do, but not in long bone osteomyelitis. The sensitivity is very low.
Andre, is there a rule of alpha defensin detection in the aspirate like in PGI, in FRI? Is there a rule?
Also not, because these alpha defensin and other biomarkers, there was just yesterday in JBJS a publication about calprotectin, another biomarker. These are all validated for synovial fluid, and there are no cutoffs for fluid outside the joint, so non-synovial fluid, such as abscess, interstitial fluid or so. No, unfortunately not. This is maybe making the trauma-related infections more difficult from the diagnostic standpoint because you have no good diagnostic.
Okay, Mustafa.
Yeah.
Mustafa, stopping at this X-ray, Mustafa, I need to ask Dr. Mu'taz. Dr. Mu'taz, in your feeling and in your clinical feeling, if this frame could stand loosening for a longer time, if this frame was stable for a longer time, was this scenario would have been able to be saved and the graft would have consolidated, or you still believe that it is infected and this was going to happen?
I think from the previous X-rays, you can be sure that there is infection. And as long as there is infection, you will expect no healing. The graft in the distal part of the femur, if you see, that is festooning. This is festooning, and this cavity forming, this is definitely filled with infected tissue and pus. You will always expect that it will fail, even if the frame will stand 2 months or 3 months longer, it will fail at the end.
And how would you salvage such case, Dr. Mu'taz?
I think we should have did the debridement on the previous X-ray 4 months. Even if we remove the graft and repeat the whole procedure, put again cement spacer, do cultures, we have to find another fixation method or change the plan of the fixator to have some stability. And then we plan for further reconstruction stages.
Christina, would you still insist on continuing with the musculae and repeating the first stage, or at this stage you would go for distraction osteogenesis?
I have a case that is very similar and I went for distraction osteogenesis.
Okay. Mustafa, could you show us please what happened?
Finally, the failure in this case was salvaged by distraction osteogenesis by a bifocal compression distraction.
Okay, proceed, Mustafa. Did you have cultures at this stage, Mustafa, or doesn't matter?
No. This stage was done 6 months after the last failure, so the wounds were totally closed. There was no, and we did not explore the fracture site.
Andre, I have a comment.
But
Yes.
Okay.
Yes,
but the
Dr.
fibular
Mokhtar.
graft, the non-union side was debrided, and every soft tissue there was removed. The fibular graft, you cannot see any remnant of it, so that it's obvious you did debridement.
Yes, yes, this was done. I'm asking about cultures because we all know, Dr. Mu'taz, that when we use distraction osteogenesis in managing bone defect, we don't care, we as surgeons in our unit, we don't care much about having cultures or giving antibiotic according to the recommended protocol. So, and we never had problems. So we never stick to antibiotic protocols and culture when we are doing distraction osteogenesis. And this is not because we believe much in Elizarov saying that infection burns in the way of distraction osteogenesis, but if we do, we are sure that we had adequate debridement and we are not using internal fixation, so we don't worry about what is the organism and give it for 6 to 12 weeks. So I need to ask Christina and Andre, in your facilities, surgeons doing the Elizarov and bone transport technique, do they still give the same antibiotics as recommended by the FRI consensus?
Who starts? Shall I start or Dr.
Yes, yes, please.
Yes, I do cultures and I do antibiotic treatment. I don't know if I would have better or worse results if I did not do them. I know I would have a better or worse relationship with my infectiologist.
Yes.
So
Yes.
it would be a lot more headaches with discussing on why I didn't do cultures and why I don't do antibiotic treatment. But this is actually proof that if you do good debridement, it can allow you a little bit more laxity in the antibiotic part of the treatment.
Yes.
And that even if you have good antibiotics, if you do not do good debridement, it will probably make healing a lot more difficult.
Okay.
Yeah.
Dr. Andre, do you want to comment on our practice, please? Frankly.
I think giving antibiotics systemically in this situation would probably indeed help. And yeah, we can of course compensate a lot with antibiotics. For example, if the debridement is not done completely good, but if there is some really sequester inside, then also antibiotics we cannot help. But yes, we use antibiotics systemically as well. Although I think in the future, we'll probably use more local antibiotics if we will have more information how to do it, or maybe even implants for internal fixation, which will be coated. I'm sure this will direction.
Okay. Okay. So you are supporting.
Mahmoud, please.
Yes. Yes, Dr. Salah.
Please, I just wanted to be a small comment. Yes, in Elizarov, we just do good debridement, but not oncological debridement. We just got, and I think we have in muscular technique, it's better to do an over debridement, what's called an oncological debridement. Yes, Mahmoud, in Elizarov technique, we burn the infection, the vascularity increase in the limb. Even we no need to do culture. We don't have problem like this. Yes, the Elizarov technique increase and burn the infection.
Just that only if you did adequate debridement, but because if you leave dead bone, Elizarov will not do anything.
Yes. We are agree. We don't leave a dead bone, and we have to remove all the dead soft tissue. But we are not concerning with over debridement. And okay. If we find a frank infection, take culture. But this is not done routinely. What I mean, this technique built inside to some factors to combat the infection. The bone transport, yes, spares the infection.
Okay, Mustafa, continue, please.
Mustafa, please go an X-ray behind, please.
Yes.
I think we missed the part. Mustafa was lucky enough that the patient disappeared and came after 6 months with resolve of all infection and all sinus closed. I want to ask for the XFX people, what are you going to do in this stage? We have just bypassed the important or the difficult part of the issue. I cannot leave a patient for 6 months with this unstable femur. Mu'taz.
I gave an answer. I gave an answer for that. We at this stage, I will do debridement for the non-union side,
Good.
and I will put external fixator in a different plane.
Yes.
Just two pins proximal, 3 pins distal, until the infection is resolved, and then we can choose another treatment option.
Okay, Mustafa, I think we need to move because we have one more case. Mustafa,
okay, here is a summary of the evidence considering this case. Graft resorption occurs normally by an average of 8.3%, considering the diameter of the graft after the induced membrane technique. This resorption was found to be greater in the femur compared to the tibia when using plates compared to using nails. And if we mix a bone graft substitute with the percentage greater than 30% of the total graft volume. The graft revascularization occurs from the periphery, from underneath the membrane towards the center. That's why an intramedullary construct should be considered whenever possible. This will reduce the amount of the graft volume required to fill the membrane, and it will reduce the amount of the central graft necrosis. Alternatively, a central core of gelatin sponge can be used in order to reduce the amount of the needed graft to fill the membrane and to decrease the risk of the central graft necrosis. Thank you so much.
Thank you, Mustafa. Thank you, Mustafa. Now I hand to Michael Amir, who is presenting the fourth case. And actually, Andre, this is an answer to your comment that our colleague, Professor Mu'taz Fuad, has adopted a local antibiotic management policy, mixing the principle of destruction osteogenesis and the induced membrane while providing local antibiotic treatment. And this is currently under investigation. We are going to discuss your opinions at the end of the case, but first, Michael has to go through two cases rapidly without comment, and we will comment at the end before we give the take-home message. Proceed, Michael.
Thank you, sir. I'm going to describe another alternative technique which was described in the literature that also includes the induced membrane technique. This is a 36-year-old male patient with infected non-united fracture mid-shaft of the left femur. The ECR was 70 and CRP was with 50. YBC count was 7.1. On first presentation to our clinic, the patient had a sinus with purulent discharge and a proximal migration of an intramedullary cemented rod. Previously, the patient had a session of debridement, which includes the removal of the hardware and fixation by LRS fixator, which was followed by another session of debridement and removal of the LRS, which was followed by a third session of debridement and replacement of the intramedullary cemented rod. This is a skin condition and a clinical photo of the patient. So the patient underwent a two-staged operation. The first stage includes the removal of the cemented rod, debridement and segment resection of the non-union site, and fixation by LRS fixator, and application of antibiotic-loaded cement spacer. The defect size was about 5 centimeters, and the culture was positive for E. coli, which was sensitive for tubramycin. Then the second stage was done after 6 weeks, which includes the removal of the spacer and closure of the induced membrane, and adding extra chance pins for the LRS fixator, and the proximal metaphyseal corticotomy was done. Then segment transfer was started after 7 days. This is an intraoperative photo showing the induced membrane between the proximal and the distal bony edges. These are the X-rays follow-up after 4 months and 6 months. And these are the X-rays after 8 months of follow-up with full consolidation of the regenerate and the union at the docking site. Then the frame was dynamized. This X-rays shows the bridging nuba formation at the docking site. Then gradual removal of the chance pins was done to complete the dynamization. And these are the X-rays after 9 months with full removal of the LRS fixator and union at the docking site with no recurrence of the infection. This is the second case, which was done with the same technique of a 35-year-old male patient with infected non-united distal shaft femur, which was done for open reduction internal fixation by a distal femur locked plate. Then revision of the fixation was done by double plating. Then the patient got infected. Then he underwent the same technique of 2 stages, with the effect size as the first stage was 8 centimeters, and the culture was positive for MRSA, which was sensitive for vancomycin. This is an intraoperative photo showing the sequestered bone. Then the second stage was done by Lazaro frame after 6 weeks, and bone transport was started. And these are the X-ray after 8 months with full consolidation of the regenerate and docking site union. And these are the X-rays after the frame removal.
Okay, okay, excellent. Christina.
Yes.
Can you explain what's happening here? Mixing the musculae and getting back to our preferable distraction osteogenesis technique. What do you think about that?
I think you create a favorable environment biologically for the bone ends of to dock without needing to add any graft or anything. Because
do you routinely graft your docking site, Christina?
I don't graft my docking sites almost ever, but I leave the fixator on probably a little bit longer. I confirm union usually with CT in my center.
Okay, so what do you think this technique has added to the docking site, other than eradicating infection?
It is possible, and this is a very, very interesting line of work. I think it perhaps could achieve union a little bit earlier because you have a more favorable biological advantage. And in addition, you also optimize the dead space that would be in the area that had been recently infected. So you also just not only regarding the antibiotics, but you also create an area where the bone can grow in.
Can I have a comment? Can I have a comment from you, Andre?
I am impressed how good you managed this case. And maybe, yeah, it's indeed that, as Christina mentioned, the local environment was favoring consolidation by suppressing bacteria.
Okay. Okay. So would you still recommend adding systemic antibiotic, Andre?
I would, because you need it for the soft tissues as well, but maybe not so long. Usually we give 6 weeks, but yeah, maybe depending also on the local status. How is it? We always give it systemically as well, and but in the future, maybe when we know more about local antibiotics, we can shorten the systemic antibiotics. Until these studies are available, I would give it as well. We are participating in a study with Martin McNally, where we compare local versus systemic antibiotics. And it's a randomized study. Hopefully this will give us more information.
And do you have special preference for the E. coli, Andre?
Yes. Either you can go for cotrimoxazole if it's susceptible, or ciprofloxacin, one of those two, if you're really sure that this is the only pathogen. Otherwise, we can give it also in a combination.
Well, I can tell you in our infection environment, cotrimoxazole and ciprofloxacin the bacteria are always resistant to it. Okay. Do we have any other alternatives?
Intravenous you have, but oral probably not.
Yeah, okay. Dr. Mu'taz, do you need to comment?
Yes, I need to show Christina something that she will face maybe in her cases. Michael, can you get the X-rays of the first case? Before shifting to the bone transport.
Regarding your technique, the one presented in the last.
Yes, this one. No. Next. No.
Perfect. You go ahead. I just wanted to add a comment to the last case.
Yes. If you can see on the medial side, this immature osteoid that started to mature around the cement. So actually, what we did when we removed the cement spacer and then we started to do bone transport, we just shrink the membrane with its osteoid. So that's why we had good healing on the medial side and anterior side and this at some stage prevented us to reach a full docking site. If you can notice this in the next X-rays.
Yes.
Next. You see this, it already healed here. So we cannot do more transport. We cannot compress the docking site. But lucky enough, when we did the serial removal of pins to dynamize, patient had no pain. He is having some range of knee motion up to 90 degrees with no pain. And it's okay. We are following him up. I hope he will not get a refracture. We'll see next year.
And how do you explain the lips on the lateral side? Do you think the membrane was interrupted there, or caught on some end?
On the lateral side, when we incised to remove, there was a little bit of the membrane with immature osteoid, but on the medial side, you can see it on X-ray. It's almost maturing.
Okay. Can you show us the evidence in the next two slides, Michael?
Yes, sir. Yes. Regarding bone transport through the induced membrane technique, is still a new technique with only 3 publications were found in the literature with a limited number of cases. And this technique is still under trial at our department at Ain Shams University. These studies has proposed the advantages regarding this technique, which includes therapeutic benefit with the local release of antibiotics from the spacer after debridement, resulting in complete remission of the infection. The second one is a mechanical benefit, which is called the spacer effect, as the induced membrane itself prevents the soft tissue invagination through the transport site in patients with large segmental defects. The third one is a biological benefit, which was proposed by the second study, which proposed that the induced membrane itself could promote the healing of the docking site without the use of bone graft due to the osteoinduction properties of the induced membrane itself and the production of the growth factors. The main disadvantage was the much greater external fixation index with a mean of 81 days per centimeter as compared to the traditional bone transport, which was 50 days per centimeter as stated by these studies. The main limitations were that these studies were not non-comparative study, whereas on the comparative study, they did not compare this new technique with a conventional bone transport technique. Also, the sample size, which was only 7 cases, were included. Also, that they did not address the docking site union problem, as primary bone grafting of the docking site was done in all the cases done by this study once the transport segment had reached the docking site. Thank you.
Thank you. Could you please stop sharing? Well, just before further discussions, this is the take-home message that we came after our experience with the musculate technique. If you ever apply the musculate technique, we do recommend that you eradicate infection first, as recommended by Musculate himself. Never applied the musculate technique thinking that musculate technique will compensate for your inadequate debridement. We should obtain proper culture sampling during the first and the second stage, as previously discussed in the first webinar. X-fix is preferable in the first stage. We delay the second stage till labs normalized, and we no longer stick to the 6 and 8 weeks period because we found no difference in membrane osteogenic potential if we wait longer. During the second stage, we have low threshold to repeat the first stage if we are suspicious, and we obtain culture samples. In a 3-stage technique, if we insist in completing with the musculate, if the second stage culture turned out positive, we repeat the first stage or shift to bone transport, and that's an issue of debate and personal variability between surgeons. And that should be the end of our webinar. We have a couple of few minutes to receive comments from the panel on any other ideas. We start by our guest. Andre, do you have anything to say at the end?
Again, I like this discussion a lot, especially that it's so open and critical, and always with some key messages. So I learned a lot, and I appreciate for your high quality seminars. Otherwise, scientifically, I have nothing to add.
Thank you. What about you, Christina?
Yes, I wanted to congratulate you on an excellent webinar. They were excellent cases, teaching cases. I learned a lot, and I wanted to thank you for the invitation. And the only thing scientifically I would wish to add as another indication for masculine that we use a lot in my hospital, we receive a lot of acute polytrauma, where, for example, with a very comminuted metaphyseal distal femur fracture, where doing a good reconstruction would be probably very complex. So those sometimes we do an acute masculine in a very similar strategy as we do with the distraction compression, but instead of doing a transport, we actually use the masculine with the plate. And
yes, I think we had a lot of successful cases in open fractures, but we didn't present these tonight. We insisted on presenting complicated and failed cases, because with open fracture we had success, but with post-osteomyelitic defect, this is where our weakness and our complications.
Yes, those are more difficult, definitely.
Yes, Dr. Salah, the head of our unit, would you like to comment?
Yes, first, I want to thank very much. Thanks for our guests for their valuable contribution. Thank you to our colleagues for their active participation. Just one small comment, please. You have also to have a plan. Muscular sometimes not go smoothly. Always keep in mind you have to shift to another plan. Don't stick. I don't like to be repeated the stage many times. You have the maximum to be at 3 stages. No more than that. Please stop and go for another plan.
Dr. Mu'taz, your final comment, please.
Yes, finally, I want to thank Professor Andre Trampouz and Professor Christina for their valuable comments and attribution in our webinar. I need to add some comment about the infected cases. The longevity of infection. A 6-month, 1 year patient presented with persistent infection. One of our cases had 13 trials, operations in a year. This is very difficult to eradicate infection after such a long period and such many surgical interventions.
Oh, Dr. Mu'taz. Wrong time. Dr. Amr, would you like to close, sir?
At the
Dr.
end,
Amr?
I will close the season, the whole season, Mahran. I am very grateful and very honored by the presence of Andre Trampouz with us in 2 webinars, in 2 successive webinars. We are very glad to share experience with this professor, with this scientific professor. Again, I'm very grateful to Professor Cristina Ojeda from Spain for sharing her experience with us. Thank you very much for being in our webinar. We hope to see you soon in Cairo. I want to ask our panel, Dr. Mu'taz and Dr. Salah Abu Saif, the head of the unit. And at the end, of course, I want to thank our distinguished speakers, Dr. Mansour, Dr. Mubaraka, Dr. Qutb, and Dr. Michael. Thank you very much, dear. And at the end, I would like to thank our moderator, our great moderator, the mastering everything, and he was the maestro of this day. Thank you, Mahran, very much. And as I told you before, this is our last webinar this season. We'll have a rest in Ramadan and the feast, and then we'll be there with you again in the 1st of June. I hope all you are well, and I hope all of us will pass this area of pandemic and this COVID, this awful COVID period. And I hope to see you all again in a very good health and the well. And thank you very much. Thank you, Mahran. Thanks a lot, and good night. Thank you.
Good night.
Sorry, Andrew, for making you late for your girlfriend. I'm sorry, Andrew. Thank you, Christina. Thanks a lot. Hope to see you here in Cairo. Thank you very much. Bye bye. Bye bye, Mahran. Shukran. Shukran. Bye bye.